Okay, we have the 15th, the 22nd or 23rd version of the Scandinavian program.
Well, I myself have been here since '95, but the Scandinavian session started in 2003.
Okay.
But I gave some speeches before.
Yeah, actually, when it started in 2003, you had some speakers who talked so long we thought it was going to end in 2004. Is that?
That's right.
But it's become a great session.
But he was a surgeon.
Yes, that's right. Okay, go ahead, Kari.
Okay, welcome to the Scandinavian Baltic session. And the first speaker is Julia Ellart. She comes from Odense, the birthplace of the fairy tale teller Hans Christian Andersen. She will not tell a fairy tale, but I think a kind of adventure, and maybe you can hear a Scottish accent when she speaks.
Good afternoon. Thank you for giving me the opportunity to present my...
Closer to the mic.
A bit down, feel free, no problem.
Good afternoon. Thank you for giving me the opportunity to present my case about a patient with percutaneous biventricular cardiac assist device in cardiogenic shock and refractory cardiac arrest. It was a 65-year-old man with witnessed cardiac arrest and initial root ventricular fibrillation, which after defibrillation converted to pulseless electrical activity. The patient was transferred with a mechanical chest compression device, Lucas, to our institution. At the arrival, ongoing CPR was 55 minutes, and upon arrival, he was severely metabolically deranged with pH 7.0, lactate 12, and anti-delta CO2 2.4. There was no history of cardiac disease, but the patient had symptoms of claudication, and the heart team consisting of an anesthesiologist, 2 cardiologists, and a thoracic surgeon decided that VA ECMO was not an option. Immediate at arrival, Implla CP was implanted under continued mechanical compression by the Lucas device, and after insertion of Implla CP into left ventricle, the device was gradually increased in flow during continuous chest compression, and it was managed to restore circulation after a total low flow time of 70 minutes. Now the echo imaging is not moving, but you can see that the left ventricle was in a reduced function with septical aneurysma, and right ventricle was here still in a good function. We continued with coronary angiogram, and that showed left dominant circulation and a chronic occlusion of the proximal LAD with collaterals from LCX. Furthermore, there was an acute occlusion of proximal RCA, and 2.5 Xine stent was implanted in the proximal RCA. And that is the final result, showing good flow and a non-dominant RCA. But despite initial stabilization, patient developed severe right heart failure, and I don't know why the movie is not. No. It's
Maybe someone click.
Yes.
Try to go back one slide.
Yeah, that I tried. Yeah. Okay. And but you can see that the right ventricle is now with reduced function, is dilated, and you could also see when the patient was run that there's a shift from the right ventricle towards the left ventricle in the septum. And there was no response for intravascular volume optimization, high-dose inotropes, vasopressors, and airway pacing. So at this point, we had to continue which options we would have for the patient. And normally, we would decide to do VA ECMO, but that was not an option because of peripheral arterial disease. So we decided to continue with Impella RP, that was implanted via femoral vein into the pulmonary artery as a right heart support. And you can see on this video the animation of implantation of Impella RP. And you can see that the inflow portion of the catheter resides in the inferior vena cava, and the flexible outflow cannula resides in the main pulmonary artery. And the device can provide up to 4.6 liter per minute of flow for up to 14 days. After implantation of Impella RP with 3.9 liter per minute of flow and Impella CP with flow of 3.3 liter per minute, circulatory stabilization was achieved and the patient was transferred to ICU. Postoperative echocardiography and chest X-ray confirms that the both impellers are in appropriate position. And on this echo imaging, you can see the location of Impella RP passing the tricuspidal valve and going into the right ventricular outflow towards pulmonary artery. And on the X-ray, you can see Impella CP locating in the left ventricle in the apex and Impella CP in the pulmonary artery. And along with the improvement of hemodynamics, there was a significant reduction in required doses of inotropes and vasopressors. Lactate was 9.6 at arrival at ICU and was normalized after 12 hours. Initial 8 hours, the pulsatility was low but not absent and normalized thereafter. The ACT was kept between 150 and 180 seconds. And the patient developed acute kidney injury with need of dialysis. Echocardiography on day 6 showed improvement of the right ventricle. Unfortunately, it's some problems with the video, but you could see that the left ventricle is now very good pumping on this imaging. And after successful device winning, Impella RP was removed on day 7 and Impella CP was removed on day 8, and the right ventricle was still in a good function, and the left ventricle was still reduced with aneurysm of septum. And there was no device-related complications with Impella CP and Impella RP, and the patient could be extubated on day 12. No neurological deficit could be observed, and he was discharged from ICU on day 25. And due to non-sustained VT, a secondary prophylactic ECD was implanted, and the patient recovered slowly and was discharged home on day 41. Cardiac and physical rehabilitation and anti-congestive medications were initiated, and dialysis was required for a period of 46 days. The patient was followed in the heart failure clinic, and 7 months later, the echocardiography showed that the right ventricle is in a good function, and the left ventricle was still reduced. Clinically, the patient was in a perfect condition. He could do mountain biking, do exercise, had a normal kidney function, and no cerebral deficit. In conclusion, I would like to say that in the setting of cardiac arrest, implantation of an Impella CP to facilitate ROSC is feasible for patients which are not found to be a candidate for VA ECMO or where some residual AV function is seen. Supporting alone the left ventricle can, however, worsen the right ventricular hemodynamics and the biventricular failure, and simultaneous biventricular support with Impella CP and RP can provide hemodynamic stability, and furthermore, use of the Impella RP allows right ventricle recovery. Thank you.
Yeah. Thank you, Julia. A beautiful story with a happy end and a very, very advanced technology. Any questions, comments?
Yes, please.
Yeah, the presentation of this guy was very adverse with a low pH, long downtime, high lactate.
Yes.
We don't use Impella. We've got a VA ECMO team that we wind in. But just give us a clue. This was many months ago, so just give us a clue as to what is your out-of-hospital cardiac arrest survival in your institution, and how many of these sort of cases have you done with what sort of success rate?
As of such a case, that's the only one case what we did when the patient came to the hospital with cardiac arrest, ongoing CPR, and which we implanted Impella CP. Normally we do ECMO implantation, but because of...
so this is a one-off?
Yes, that's the only one case. And when you look into the literature, I also could not find similar cases in such a combination.
Thank you for an excellent case presentation. I've got a question and remark. Was it a tall man or a small man? What was the body weight of the man? We have sorted out the difference between 2.5 and 4.0 liters. And there's a huge difference in outcome in patients like this. We have studied 45 patients in cardiogenic shock between the 2.5 and the 4 in advantage of the 4.0. And I even do think that there should be a Impella that produces more than 4, 6 or 7. There are, but with a femoral approach. So was this heavyweight or lightweight? Because there is, of course, a correlation between the body weight and the effectiveness of a 4.0 liter Impella.
He was around 80 kilos, also not especially overweight.
I have a couple of questions.
Oh, sure.
How many people in this room would have started this case? I personally, and I don't mean it, I didn't mean it critically, but after 70 minutes of CPR, I'm not sure I would have done anything. So I congratulate you. My last question is, where can you go mountain biking in Denmark?
May I comment on that? I think the situation in Europe, especially in Denmark, and I know about the Netherlands, is maybe different from in the US, because in my country the ambulance will be there mostly within 10 minutes. I don't know about, so resuscitation is started quite early. And this kind of people, that when they come in, you have to make up your mind. Sometimes you think it's hopeless, sometimes you think, well, and I don't know whether it has something to do with age or whatever, but you will start in most of the cases.
Yeah.
And your second question was?
Where can you go mountain biking in Denmark?
Yeah, that's where you can go mountain biking in Denmark.
Oh, you can do a lot of, maybe not mountain biking, but a lot of biking in Denmark. But I'm not a biker, so I don't know.
Okay, thank you so much.